Hi, welcome back to the Blood Bank Guy video podcast. My name is Joe Chaffin. It is February 2012, and today we're going to be covering pre-transfusion testing. This is part 2 of the basic immunohematology series, and we will talk a little bit more about that in just a second. First, though, I'd like to thank you for the comments that you've sent my way regarding the previous podcasts, including the comments that have come through the Blood Bank Guy site, especially things like this. It's nice to know that I stink. I appreciate it. Truthfully, not many people have said that, but I enjoy the ones that do. Don't flood me with you stink emails, by the way. All right, so also through the Facebook page, which is facebook.com/bloodbankguy, I get a lot of comments through this page. And in fact, we just hit a milestone recently where over 500 people now, quote unquote, hate that phrase, the Blood Bank Guy on Facebook. I just want to remind you, if you notice right above where the 501 number is, you see Blood Bank Guy or BB Guy Vimeo videos. So you can watch these videos actually directly on Facebook if you so desire. I also have had a lot of mentions and comments through Twitter. I'm happy, very happy to when that happens, and a lot of direct messages that people have sent me through Twitter as well. So thank you for all of those. With that being said, let's move on and talk about the series that I mentioned at the beginning. The basic immunohematology series started with the Blood Groups Overview podcast, which was recorded and released in December 2011. Today is number 2, the Pretransfusion Testing podcast, February 2012. The basic antibody identification podcast will be released either on the very last day of February 2012 or the beginning of March 2012. And the Advanced Antibody ID podcast, which there may be more than one of those. I'm warning you in advance, but certainly at least one will be released later in 2012. We'll announce that as we get closer. So today, what we're going to do with pre-transfusion testing is start with an overview, just basically what are we trying to do, what's our goal, and then second, talk about the testing methods that are used in pre-transfusion testing, go through those in great detail. We covered some of that in the basic blood groups overview section, but we'll go into a little more detail this time. Next, the components of the process, specifically what do we need to do in order to get a particular blood product ready for release from the transfusion service. And then finally, we'll hit a little bit of nomenclature just to make sure that you understand clearly some of the terminology surrounding pre-transfusion testing. So, what are we trying to do when we're doing pre-transfusion testing? In other words, when we're doing the testing that we are required to do before a blood product leaves the control of the transfusion service and goes either to a patient in the hospital or to an outpatient or whatever the case may be, is that we're trying to choose the most appropriate blood product from a safe, compatible donor and infuse that product into a properly identified and thoroughly tested recipient. Basically, we're going to spend the rest of our time together today kind of beating that to death and figuring out exactly how to do that. As you can imagine, like most things in blood banking, pre-transfusion testing is regulated. CLIA sets the minimum laboratory standard for blood banks and laboratories in general, and also has a few specific regulations surrounding pre-transfusion testing. But honestly, CLIA doesn't tend to inspect laboratories all that much, in particular transfusion services all that much, because there are organizations such as the AABB and the College of American Pathologists that have what's called deemed status, meaning that if you successfully pass, for example, an AABB inspection, you can use that inspection to satisfy the requirements of CLIA. It's not mandatory that you do so, but you can do it. The FDA, on the other hand, at the bottom, doesn't do a lot with pre-transfusion testing. There are some things that we'll talk about later in terms of the FDA's mandating which antigens need to be represented on antibody screen cells. But aside from that, they're not nearly as involved in pre-transfusion testing as they are in the production of the red cells or the other components in the blood center. Here's the big picture, and you'll see this on the bottom of page 1. If you notice at the bottom left-hand part of your slide, you see page 1 written there. Most of the slides will tell you exactly where we are in the handout. If you have not downloaded the handout, pause this podcast, go to www.bbguy.org, click the podcast tab and follow the directions to the handout for this particular podcast. Anyway, so if you notice up at the top, there are things that the blood supplier does in terms of testing of the donor, and there along the bottom there are things that the transfusion service does. And we're going to focus primarily today on stuff done in the transfusion service. Your handout will talk a little bit about what the blood supplier does. We're not going to spend a whole lot of time on that. Mostly the things in blue. This is another way to look at it from an article in January 2006. Basically, you receive a properly labeled specimen at the blood bank. You do the ABO testing on the bottom of that fork in the road, antibody screen at the top. If there are no unexpected antibodies, and if you determine the type appropriately, then you select an ABO compatible donor unit, do a cross-match, recipient plasma mixed and centrifuge with sample of donor red cells, and then issue the unit. That's the general outline of how it's done and has been done for years. There's some variations on that we'll talk about momentarily. Okay, let's go on and talk about the basic reactions in blood banking. The things that we look for. Certainly, agglutination, as we talked about in the last podcast, is the most basic reaction in blood banking. It's the coating and then bridge formation of red cell antibodies. You see illustrated in the images on the right. There's a lot of different things that go into making the coating work better and making the bridge formation happen better, and we'll talk about those individually as we go along. Now, hemolysis, you should be aware, is also actually a positive test in pre-transfusion testing. In fact, it's the ultimate positive test. It's basically direct red cell lysis as a result of complement fixation. It doesn't happen very often in our testing, but it can. And remember that it's just as much a positive as agglutination. IgM antibodies in particular do that fairly well. When we're talking about the binding of an antigen to an antibody, in this case, the binding of a red cell antibody to its associated red cell antigen on the surface of a red cell, basically it's a chemical reaction. And you guys remember chemistry, right? It's been a while for most of you, I'm sure. But basically, an antigen plus an antibody has a reversible reaction with an antigen-antibody complex. And basically, what we're wanting to do when we're doing pre-transfusion testing is we want to shift that equation to the right as much as possible. In other words, we want to see if there is an incompatibility between an antibody and an antigen. We want to see that antigen-antibody complex stay together so that we can detect it. Like most chemical reactions, there's a K0 or an equilibrium constant, and basically the higher the number for the K0, the more stable reactions there are. There's a lot of factors that influence that affinity and determine how well antigens and antibodies stick together, and we're going to take a little while to go through some of those right now. The first is thermal range. Well, basically, antibodies have a couple different ways of reacting. Some of them react better either at the immediate spin or 37-degree phase, more on that in just a moment, and others react better at warmer temperatures, the anti-human globulin phase. In general, the cold reacting ones are insignificant IgM-related antibodies, with one significant exception, and that's with ABO. But normally those cold reactive IgM antibodies react against carbohydrate antigens like ABO, Lewis, big I, little I, P, M, and N. The warm reactive antibodies, on the other hand, are normally IgG, and they're more commonly significant, and they're usually reacting versus protein antigens, such as the ones you would think of, RH, KEL antigens, KID antigens, Duffy antigens, etc., all the things that we talked about in the last podcast. Second issue that we have to deal with when we're trying to make an antibody agglutinate red blood cells is that the size difference between an antibody and a red cell is spectacular. Red cells are more than 700 times bigger than antibodies, and you can think about this way: that if a red cell was 100 yards long, the distance of the length of a football field, so you can imagine that in your brain, big old football field size red cell. If that were the case, then a single IgG molecule would be about 5 inches long, which is actually smaller than a single football. So how is that little guy going to agglutinate big honking red cells? Well, there's a lot of things that we can do to try and influence that. Among them, centrifugation, to try and push those two, push the red cells closer together to make it easier for the antibodies to bind. I just want to illustrate this for you. So we have this image of two red cells sitting there. Okay, they're just kind of sitting there peacefully, and then an antibody comes along and grabs onto them and binds them. And that seems reasonable, and we've seen that drawn before. But the reality is, when you talk about the size difference, here's how that antibody compares to those two red cells. Yeah, you really can't see it, can you? Well, let's zoom in a little bit. it's still pretty darn small. So we're really talking about a spectacular job for this little tiny antibody to try and bind to two red cells and bring them together. Obviously, you need more than one antibody. Obviously, you need a lot of other things going on in order to make that happen better. Well, there are some other factors that are kind of fighting against us, and that includes electric issues. Basically, red cells have a net negative surface charge due to sialic acid residues, and those negative charges actually cause the red cells to repel each other. Obviously, if you two red cells are trying to come together and they're both negatively charged, obviously electrically that's going to push them apart. That's something called zeta potential, and that's a very elementary explanation of zeta potential, but that's basically what keeps those red cells from getting closer together. Zeta potential applies when two surfaces are both negative, and it also applies when they're both positive, that you'll see in just a second. Here's kind of how that looks. If red cells are suspended in normal saline, remember we have the red cells have that negative surface charge due to sialic acid at the surface. If you're talking about normal saline, you got a lot of sodium ions floating around, and that's those pluses in the top left of the screen. Well, as you can imagine, if red cells have a net negative surface charge, those sodium ions are going to be attracted, and they're going to go and they're going to cluster around the surface of the red cells, ending up with functionally the same thing, just opposite charge of a net positive surface charge if those red cells, if those sodium ions have their way. Either way, with a net negative or a net positive, you have repulsion of the red cells. And that ionic cloud of ions that surrounds the red cells can keep those red cells from getting really close together. That's zeta potential, again, as I mentioned before. Basically, the distance that red cells tend to equilibrate apart from each other as a result of the zeta potential is about 14 nanometers. And ironically, that distance, that diameter of 14 nanometers is as far as a single IgG molecule can spread. So you can understand why we'll say just in a minute that an IgG by itself has a difficult time agglutinating red cells. It can bind to the red cells, but forming bridges is hard because red cells don't get that close together. IgM has a much bigger diameter of 30 nanometers, still small relatively speaking, but has an easier time doing direct agglutination. The other thing that you should remember about what happens with normal saline is that antibodies actually at pHs in which we do our testing have a mildly positive surface charge, so that they can actually bind better to the surface of that negative surface of the antibody. Well, remember, we've talked about sodium ions, but there are also chloride ions. So with normal saline, the chloride ions can go and neutralize the antibodies as well. So basically, normal saline is not the greatest solution to do our testing, and that's one of the reasons that we use things like low ionic strength saline. Now, LIS actually has fewer sodium and chloride ions, so in the same scenario that I showed you at the beginning, there are fewer positive ions to go and grab onto the surface, and so you get less of an ionic cloud and potentially less zeta potential as a result of that, and fewer chloride ions to neutralize those antibodies. This is a busy slide that talks about lists. The most important facts are found in the second and fourth bullet, which is basically that normal saline, by comparison to low ionic strength saline or LIS, normal saline has about 4 times more sodium and chloride ions. That's the bottom line with it. So LIS helps potentiate reactions as a result of that. More on potentiators in just a second. Now on to pH. Well, pH, obviously you know the normal body pH is about 7.4, but most of our reactions that we do in the laboratory react best at a pH of 7.0. 7.0 gives you a net negative charge to the red cells, and most of the antibodies present have a positive charge, so you have a natural attraction there. If you go too far down, though, with the pH, you'll actually lead to dissociation of a lot of antibodies. Not all. There are certain IgM antibodies, such as anti-M, that like to be lower, but basically that's one of the ways that we can elute antibodies off the surface of the red cells, by dropping the pH to a lower point. Next, in terms of the factors that influence whether or not we're going to be able to do an antibody-antigen interaction, is the relative concentrations. Normally, in blood bank testing, we use 2 drops of serum for every 1 drop of 2 to 5% red cell solution. But that's not really hard and fast. That's not definite and set in stone. You can manipulate it by adding more serum drops, and reference labs do this quite often, or using less concentrated red cells to basically increase the ratio of the serum to the red cells, or increase the ratio by by direct extension of the antibody to the red cell antigens. You have to be careful with that, though. There's a phenomenon known as the prozone phenomenon, which is illustrated on the left side of this slide. Basically, when you have too much antibody excess, you can be in a position where all the antigen binding sites are taken up by those antibodies. All the antibody binding sites are taken up, and you end up in a situation where the red cells can't agglutinate. There's nothing left. There's no open spots for them to form bridges. In general, there's most blood bank tests use a moderate antibody excess, but not to the extent of getting to prozone. Finally, let's talk just a little bit about direct versus indirect agglutination. We kind of alluded to this before. Direct agglutination is a one-step process. Basically, antibody binds to at least 2 red cells at once in the case of IgM and forms bridges right away. That happens much more commonly with IgM. You can see IgM is a pentamer, IgG is only a monomer, and IgM has a wider diameter and can bind to more things. Obviously, 10 binding sites versus 2 binding sites for the IgG. So much more common for a direct direct agglutination to occur as a result of IgM interaction. IgG, on the other hand, tends to do indirect, basically coating the red cells, but not necessarily agglutinating. And you end up needing another test, such as an indirect antiglobulin test that we'll talk about in just a moment, to determine that the red cells have been coated by the antibody. Okay, we've talked about tube testing before, so we'll zip through this. You remember we talked before about the 3 phases of tube testing: the immediate spin phase, the 37-degree phase, and the AHG phase. Let's just show you that graphically because I don't want to look at that slide anymore. Here's basically how it works. So when we start from the left of the slide, basically we have a test tube. Or whatever reagent system you're working with. You have a test tube that has antibodies in it or potential antibodies in it. You mix those with red cells. You can do it either way. You can start with red cells and start with known red cells and look for antibodies, or you can start with serum and look for known serum and look for specific unknown red cells. In this case, when we're talking about compatibility testing, when we're talking about doing the indirect antiglobulin test down the line, basically we're using patient serum with reagent red cells. Okay, so when we're trying to do our test, this is what we use. We mix those two together, spin them, and you look for direct agglutination. That is the so-called immediate spin phase. Okay, great. Well, once you get to that point, you need to do an incubation, add your potentiator, which can be low ionic strength saline that we talked about before, and a couple others that we'll talk about in just a second. Incubate those at 37 degrees, centrifuge again, read the specimen to look for agglutination. That's the 37-degree phase. Then moving on to the IAT or AHG, anti-human globulin phase, the first thing you always have to remember when you move from 37 degrees into AHG, you always have to do a wash. You wash to get rid of any unbound globulins that could cause a false negative by the by the anti-human globulin binding. And so over the wash word there, you see anti-human globulin, which are antibodies against human antibodies. They bind to coated red cells, cause visible agglutination, and that's the IAT or AHG phase, as the case may be. Potentiators, we already said, are added prior to 37-degree incubation. We already talked about LIS. We'll say just a couple words about albumin and PEG and talk about proteolytic enzymes later, though they're not really a potentiator used in routine pre-transfusion testing. Albumin comes from bovine sources. It's 22% concentration. Basically, albumin also reduces zeta potential in a little bit of a different way and gives you a somewhat different incubation time. PEG, or polyethylene glycol, is a water-soluble polymer that by its nature excludes water from around the red cells. It helps to decrease that ionic cloud. It helps to basically allow the red cells to get closer together as a result of concentration. Water moves away, red cells can get closer together. The important thing you have to remember about PEG is that PEG causes nonspecific agglutination at the 37-degree phase. So most labs that do PEG testing will not even do a 37-degree phase. You certainly have to remove the PEG before you go to the indirect antiglobulin phase because you will get nonspecific agglutinates. So here's just a slide reviewing how we do this in terms of what potentiators lead to what incubation times at 37. If you just do saline, no potentiator at all, you have to incubate for 30 to 60 minutes. Well, most labs don't like to do that, so they do other stuff like albumin for 15 to 30 minutes, or more commonly, low ionic strength saline, or LIS, gives you a 10 to 15 minute incubation, much better, and the same thing about 15 minutes or so with PEG. That's kind of an important slide to know, so be aware of those differences in incubation times. Once you do all this, you have to interpret the testing, and let's take a look at how tube testing is interpreted. Here's some images that the folks at Immucor were kind enough to give me, and I give credit to them. Thank you very much for that. Basically, if you look on the left side of this slide, you can see a very strong single agglutinate at the bottom of the test tube. That's a 4+ positive on the 0 to 4+ scale. Now, some laboratories use a 12-point scale, 0 to 12, and that would correspond to a 12 on the 12 scale. You move down, basically 3+ and 2+, you can see the agglutinates are less, and you have a clear background for both of those. Moving on to the right side of the screen, you see that the 1+ and the 0+, you actually have a turbid background. That's the difference between 1+ and 2+, by the way, is not only the turbid background but larger agglutinates, but turbid background corresponds to 1+. And again, you can see 0+ or 0 in the 0 to 12 scale, no agglutinates, no visible agglutinates whatsoever. I'm not hugely experienced in the 0 to 12 scale. I have not worked in a laboratory that uses it. There's definitely more options, and this shows you some of those options. This next slide, I know this is a little blurry, but you can see that there are variations and increases in strength as you go down this slide. But this starts with 0 on the left and moves on to 4+ on the right, and with the 0, 2, 5, 8, 10, and 12 in the 0 to 12 scale. Again, just showing that for your reference. All right, so gel testing, on the other hand, is an alternative to tube testing that we covered the very, very bare basics of it last time. But let's talk in a little more detail here. Basically, gel testing is done in little individual microwells, or microtubes, I should say, and those tubes contain an actual gel, which is a semi-viscous solution basically, and that gel in general, in the most common way this is done, is impregnated with anti-IgG. That anti-IgG is designed to grab onto IgG coated red cells as they go by, and to keep them from going to the bottom of this microtube. That's the basic principle of it. So here's how it works. You take one of these little microtubes, you add red cells, you add plasma, and you incubate and centrifuge. The nice thing about gel is that the plasma actually stays at the surface, and the red cells, if the red cells presumably coated with antibody, or potentially coated with antibody, they're moved down through the tube as the centrifugation happens. Well, obviously, there is not only gel in the tube, but there's anti-IgG, so if there are agglutinates right away, they're going to be stopped somewhat by the gel, and if the anti-IgG grabs onto coated red cells, those red cells are going to be stopped as well. Basically, it correlates the distance the red cells drop down into the tube during centrifugation correlates to how coated they are. And here's how that looks. If there's no coating of the red cells whatsoever, the red cells scoot all the way to the bottom. If there is coating of the red cells, then they're grabbed at some point along the way to give you a positive reaction. And here's a real live look at how that looks. You notice on the left the 4+ positive, where the red cells are stopped right at the top of the tube, and different variations or different levels of passage through the microtube on the way down to a complete negative on the far right. I hope that makes sense. Gel testing is being used very commonly in the United States, and it's more sensitive than LIS testing in general, and about the same sensitivity as PEG testing. A little disagreement on that in different circles, but that's how I generally consider it. Solid phase testing, on the other hand, is also popular as an automated method primarily, but it can also be done without the use of automated equipment. And here's how solid phase testing works. Let me show you this, and hang with me here, because this is a little difficult to understand when you just look at the results. So we're talking about a very small little micro well, tiny little micro well, size of the nail on your little finger, basically. So tiny little micro well, and on the bottom of those wells, when we're doing our pre-transfusion testing in general, what you'll see, well, you won't see actually, because there'll usually be lysed red cell antigens on the bottom of that well. They're antigens from a particular donor against which we're trying to test compatibility as part of an antibody screen, for example. More on that in just a second. So you add your patient sample, your patient serum or plasma sample, as the case may be, that if there is incompatibility, if there's an antibody against one of those antigens that's on the bottom of the microwell, then basically the antibody will bind. But you can't see that. So you need something else in order to see that. And the way you see that is through the use of indicator red cells that are coated with anti-IgG. So that blue antibody there is an anti-IgG, anti-human globulin basically. It binds onto that IgG on the surface, and so the red cells, the indicator red cells at the top, will be shown in a kind of a diffuse carpet across the bottom of the well, and that's why it looks like this. If you look on the right side of this image, basically you'll see a 4+ positive is a very strong is a very diffuse carpet of red cells across the bottom, while a negative is a strong button. And you saw the pictures before from tube testing, so please remember how this looks. It's really easy to mix this up, and to call a negative in solid phase actually a positive. It's exactly the opposite of how tube testing looks. Basically, across the bottom of the screen, you see going from 4+ to 0+, and the differences that can occur in between. Both solid phase and gel testing can be automated with the use of some of the equipment seen here, and this is just a sampling of the equipment that's available from these companies. But there absolutely can be automation of this testing to make things go smoother and easier theoretically in the transfusion service. So let's talk about this a method comparison. I actually left this out of the handout. Please forgive me for that. I will try and fix that down the line. Actually, check the very end of the handout once you download it, because I'm trying to add this on to the very end as an appendix. Okay, so comparing the methods, the most common methods that are used in the United States include tube testing with LIS as a potentiator, tube testing with PEG as a potentiator, gel system, and solid phase system. So in terms of best sensitivity, well, I think I would say, as I said before, PEG and gel and solid phase are about the same. They're a little bit better than LIS. One of the things that's interesting is that PEG in particular tends to enhance warm autoantibodies, and sometimes you can get some false positives with that. Gel and solid phase do that as well, not quite as much as PEG, but not far behind. LIS potentiation in tubes actually enhances cold autoantibodies, so unfortunately you sometimes see things that you don't really want to see. The next three columns are really all about gel and solid phase. They give the most stable reactions, things that can be reviewed later on down the line by a supervisor or other technologist. They are unfortunately the most expensive tests to do, and they both can be automated. So a nice comparison between all these methods for you to hang on to. A few more things before we get into more specifics about pretransfusion testing. The direct antiglobulin test, the indirect antiglobulin test, we've kind of already outlined it. Basically, what we're looking for is coating of the red cells in vitro, in a test tube, as the case, or in whatever medium you're using. And the yellow antibody there is anti-human globulin that shows you that those antibodies have been those red cells have been coated, but not necessarily agglutinated. There's lots of different kinds of anti-human globulin you can use. Excuse me, I'm sorry about that. There's lots of different kinds of anti-human globulin you can use, including anti-IgG. Anti-IgG and C3d is called polyspecific AHG, and a lot of labs will start with polyspecific, and then if that's positive, then they'll do one of the next two, which is specific anti-IgG and anti-C3b or C3d. Fundamentally, the anti-IgG does exactly what you would think it would do. It picks up IgG on the surface of red cells, not completely specifically, but mostly. There can be some overlap. Anti-C3d, on the other hand, shows that complement has been fixed on the red cells and gives you a clue that there may have been another type of coating, such as with IgM, which is better at fixing complement than IgG. Anytime you do a test that requires a wash phase, you have to do what's known as a Coombs control, also known as check cells. Basically, these Coombs control are the purple cells here. They're coated red cells. They're red cells that have IgG and or complement on their surface. They're added to a negative indirect antiglobulin test to make sure that your AHG is working well. By definition, a Coombs control or the check cells should be positive because they're coated red cells. If anti-human globulin is there and working, you can go ahead and you should go ahead and see a visible agglutination. Um, you don't have to do this for a test like gel because the plasma doesn't actually go through the gel system with the red cells, but certainly you have to do it for tube testing. All right, the direct antiglobulin test, on the other hand, does the same. It's basically the end stage of an IAT. It's just taking a sample from someone's peripheral blood and looking to see whether those red cells were already coated in the body. Don't forget there's a wash phase. You always have to wash to get rid of unbound globulin. But other than that, the DAT is done in the exact same way that the end of an IAT is done. Your handout talks about some of the indications and uses for the DAT. We don't have enough time to go into all of those, but there are definitely some useful things that the DAT can help you with, especially in terms of transfusion reaction workups. That you can review those briefly in the handout. All right, so some additional tools that are in our arsenal when we're doing pre-transfusion testing include the things that you see on this slide, your enzymes and pre-warming, adsorption, elutions, and other treatments of the red cells. Let's talk about those very briefly. And I showed you this illustration before, but I love it so much I have to do it again. So in the last podcast, we talked about the fact that enzymes like physin and papain can change antigen expression, may either increase antigen expression or decrease antigen expression, or increase the availability of those antigens or decrease the availability of those antigens to bind to antibodies. Here's what I mean by that. Here's just one example. So we have the surface of a red cell, and let's look at it up close. And in this particular case, we're going to look at the antigens that carry, the chains that carry the M antigens. These are glycophorins, and those glycophorins stick fairly far up from the surface of the red cell. Well, you add a proteolytic enzyme. Those glycophorins are proteins, and those glycophorins, those chains can actually be grabbed by proteolytic enzymes, cleaved, and you end up with a situation where you have fewer antigens on the surface, or maybe even completely destroying them. So that's one way that you directly change antigen expression. On the other hand, you can have a situation where, for example, with an antigen like Rh, that's illustrated in blue, those Rh antigens tend to be considerably closer to the red cell surface, and if they're being masked to some extent by those glycophorins that are sticking way up, well, an antibody can come along and may have an issue getting down to that Rh antigen. Now, you and I both know that that's not usually a big deal because Rh antigens are expressed well enough and the antibodies bind them really well. But if you throw in a proteolytic enzyme to this situation, goes along, does its work, and you get loss of some of those glycophorins, well, guess what happens then? Then the antibody is able to move on and bind even better to those underlying antigens. Here's a schematic of the red cell surface, and this kind of shows you again at the far left is a glycophorin. Pardon me. Far left is a glycophorin that sticks way up from the surface, and if you look in the middle, those are the Rh antigens that are very close to the surface. This is obviously a very busy slide that has a lot more than that, but it just kind of illustrates the principle. So in terms of how this works, this is what I use in the last podcast to describe and discuss the different blood groups, and it's the enzyme classification. And again, you see all these here. We talked about them before. I'm not going to go over them again. Pre-warming, on the other hand, is a way to incubate reagents and samples at warm temperatures in order to mask cold antibody activity, and that includes both cold autoantibodies against your own red cells and alloantibodies against someone else's red cells. People like to do pre-warming because it's a way to kind of get rid of some reactions that you don't really want to see, but you have to be careful with it because pre-warming actually can weaken significant antibodies, and it really should only be used as confirmation. Don't use it to just make the reactions go away and say, oh yay, I'm done, there's nothing there. You really need to take a close look at what you're doing and figure it out as best you can before you go to pre-warming that should be used just to kind of confirm your initial impressions. Adsorption, a commonly used phrase that is poorly understood by a lot of beginning students in blood banking. Basically, adsorption is a way to remove antibodies from a sample by incubation with antigen-positive red cells. And you can do this in a couple ways. You can do autoadsorption and you can do alloadsorption. Let's start with autoadsorption. Let's just imagine that we have a patient who has an autoantibody. Let's call it a warm autoantibody. So it's binding to basically all the red cells, as autoantibodies tend to do, and you're getting complete incompatible reactions. Well, unbeknownst to you, this person also has an anti-big K underneath that autoantibody. But if the autoantibody is masking all the reactions, you may not be able to tell that there's an anti-big K there. So as part of the workup, one of the things that you can do is an auto-adsorption where you add the patient's own cells, which are presumably big K negative because the patient's made an anti-big K. And those cells basically, you just think of it as a sponge. They basically adsorb or soak up that autoantibody. So you're left with a situation after you separate your sample from your red cells, you're left with a situation where you have autoantibody coating the patient's red cells, and left behind in the sample is the anti-big K. You can then go on and test that sample, and which is basically adsorbed serum, and show that it actually has an antibody. That's very important in terms of what red cells you're going to select for transfusion for this patient. Again, you can do alloadsorption, which is looking for antibodies against someone else's red cell antigens. Again, let's go hypothetical. Let's imagine we have someone who has an anti-big K, an anti-big C, and an anti-big S. And when we're doing our testing, we kind of know that there's some stuff there. We can identify the anti-big K and the anti-big C, for example, but we're not sure. It seems like there's something else there, and we want to figure out what it is. Well, one of the ways that we can do that, again, is to throw in some red cells that are specific. In other words, let's, in this case, throw in big K positive, big C positive, but big S negative red cells. Again, same principle with adsorption. You would expect those red cells to adsorb or soak up the anti-big K and the anti-big C and leave behind a sample that has the anti-big S. And you can then test that adsorbed serum and determine that that anti-big S is there. The next thing we'll talk about is elution, and elution kind of goes along with adsorption in a lot of cases. Let's stick with this same example. So we've got those red cells that are coated. What are we going to do with those? Well, one of the things that we can do is take those coated red cells and do an elution, basically through treatment with either heat or cold, including freezing if necessary, but most commonly in a lot of blood banks, that chemical treatment with something like glycine will actually cause those red cells to give up their coated give up the antibodies that are coating their surface, and give you a sample that you can use to test that shows anti-big K and anti-big C. So you can test those and figure those out, and you're left behind with the red cells that don't have any coating on them anymore. Now, that doesn't always work. Some of the things that we do can be pretty tough on those red cells, so you may have them there, or you may end up in a situation where you just kind of flame them and there are no red cells left. But most important in an elution is looking for that the sample and the antibodies that may be in it. Moving on, there are some agents that we can use to treat red cells that kind of change how they react, including DTT, or dithiothreatol. It's a sulfhydryl reagent that destroys numerous red cell antigens, such as big K in particular. Kel antigens are destroyed by DTT. In addition, you can use DTT because it's a sulfhydryl reagent. You can use it to deactivate IgM antibodies in serum or plasma samples. The reagent basically dissociates the bonds that make IgM a pentamer, and you end up with no activity of the IgM. The same thing for tumor captoethanol 2-ME, which does the same thing as DTT in terms of that IgM. ZZAP, on the other hand, is a combination of a proteolytic enzyme and DTT, so it does exactly what you would expect. It deactivates the antigens that enzymes deactivate, strengthens the ones that they strengthen, and DTT comes along and damages the Kel antigens, for example, and whatever else DTT damages. Chloroquine is used sometimes primarily in reference labs. It's used to strip IgG from DAT positive red cells. That's most commonly used when someone has a positive DAT and you're trying to tell what their actual phenotype is. Perhaps you're trying to figure out how to transfuse them. Well, you can use chloroquine to get that IgG off of the surface of those coated red cells. It also removes some residual HLA antigens called the BG antigens from the surface of red cells. Okay, so we've talked about that for a while. I hope you feel like you have a solid background in the terminology and technology that we use. Let's spend a little while now going over the components of pre-transfusion testing. It starts with the donor sample and the testing of the donor sample. Remember, this is the sample from the product that's going to be transfused. Transfusion services have some activity to do here, but truthfully, most of it is done in the blood center. On page 8, it goes over all the things that are done in the blood center, including the different requirements for testing, and we're not going to talk anything about that today. But in the transfusion service, there's some confirmation of some of that testing that we have to do. We have to do ABO testing, and you only have to do, whoops, sorry about that, you only have to do the forward group. I'm going backwards. All right, there we go. So you only have to do the forward group when you're doing the reconfirmation. Basically, just making sure that the way that the product is labeled is what's appropriate. RH testing, you only have to confirm those that are labeled as D negative. You don't have to do a weak D test that we've talked about before, and we'll talk about again in a minute. And also, you don't have to redo all your confirmation of your infectious disease test. That's good news, right? So now that we've tested our donor sample and we have products sitting on the shelf that are ready to go, let's start working on our patient. What are the things we have to do for our patient? Well, it starts with a good collection. Identify. It's so important to properly identify the patient who's going to get a transfusion. If you don't, if the staff that's doing the phlebotomies don't do this well, you end up in calamitous situations. In particular, one of our worst nightmares in the blood bank is the WBIT, WIBIT, or wrong blood in the tube, which occurs, according to some studies, in 1 in 2,000 samples. That scares us because we can do all our testing right and still be in a situation where a patient has a problem as a result of the fact that it was garbage in and garbage out. So the steps to collection include the generation of a request, whether that comes from the computer or it's handwritten, identify the patient using a wristband, compare that patient information to the information on the request, and please make sure that it matches. If you're someone who works in doing phlebotomy, it's so important. The smallest mistake can cause your sample to be rejected, and you have to redraw a patient again for testing. Nobody wants to do that. Nobody wants to tell you to do that. So please do it right as often as you can. So you draw your tubes, and then you do your labeling at the bedside. More on that. The tube has to be labeled at the patient's side. It's not acceptable to label them at the nurse's station beforehand or at the nurse's station afterwards. If you do that, it is absolutely a recipe for error and a recipe for disaster. I have seen this. It's not pretty. It's so important, especially in hospitals today and in outpatient transfusion centers today. There's so much going on. The best thing that you can do in terms of getting the sample done is to do it at the patient's bedside right away, right then, after you draw it. What do you need to do? Well, you need to put 2 independent identifiers on that tube, whether full name, unique ID number, birth date, social security number, etc. We have to have a way to identify the phlebotomist. It's very important that that's the case as well. Okay, so all those things are important. Once the sample gets to the transfusion service, then the transfusion service has a job to do. Basically, they have to first compare the information on the request to the information on the tube. And I mentioned this before. It's got to match. It's just that simple. It has to match. And I'm very serious about this. I am incredibly strict about this, and it's not always the most popular thing in the world, I'll tell you that right now, but I require redraws if there's any discrepancy. I very strongly believe that data shows, including this study from 1997 listed on this slide, but data shows that it's a bad idea to allow relabeling, and that if a sample does have even a seemingly insignificant error, there's a 40% chance that there's something wrong with that sample. So a 40 times chance, I should say, that there's something wrong with that sample. So I don't mess with it. They need to tell us what's needed and when it's needed. We need to have a way to identify the ordering provider as well as the phlebotomist, as I said before, and what modifications are needed. Does it need to be washed? Does it need to be leukocyte reduced? Does it need to be irradiated? Whatever. So all those things are important. The other thing we evaluate is how long that sample is going to be good, and that leads us to a discussion of what we call the Q3-day rule, or the every 3-day rule, very commonly misunderstood by folks. So let's talk about it for a second. Let's imagine someone comes into the hospital. It's Sunday. They get their sample drawn for pre-transfusion testing. They may need a transfusion. We're not sure. And it's 2 o'clock in the afternoon on Sunday. So that sample gets drawn. Sunday immediately becomes day 0. Obviously, Monday, day 1, Tuesday, day 2, and Wednesday, day 3. So for anything that's done for this patient, any compatibility testing, any cross-matching, any blood typing, etc., that's done on this patient between now and midnight on Wednesday, in our example here, that same sample can be used. Now that's technically only true if the patient has been pregnant or transfused within the last 3 months. If the patient hasn't been, then the 3-day expiration doesn't necessarily apply, but I will tell you that most transfusion services just make it 3 days. Excuse me, just make it 3 days because it's easier to do and it's harder to determine who's been pregnant, who's been transfused. So most transfusion services will just make it 3 days. Thursday comes along in our example, patient needs a transfusion again. Well, they're going to need a new sample, and then Thursday becomes day 0, and the cycle starts all over again. I hope that helps helps you understand. Here it is in words. You have to have a new sample every 3 days if the patient has been transfused or pregnant in the preceding 3 months. If it has not been a pregnancy or transfusion, theoretically you can extend that to whatever time is allowed on the package insert of the reagents and on the sample tubes that you're using. There is no upper limit, and if you talk to different people in different places, you'll see substantially different upper limits. More on that in just a second. You also need to keep the sample for at least 7 days post-transfusion. So what that fundamentally means, because you have 3 days on the front and 7 days on the end, most transfusion services will keep samples for at least 10 days from the time that it arrives. So weird situations include pre-op or outpatient surgery, especially nowadays with patients coming into the hospital to get their blood work done and then not having surgery until the next day or the day after or a week later or 2 weeks later or whatever. There's a lot of different ways that we can figure out to try and utilize that same sample, and your handout talks about some of those. It includes making the patient just wear the blood bank wristband for 2 weeks or whatever. Doesn't necessarily work all that well, but there are a lot of creative methods that we can do. Again, you can only do that if the patient has not been pregnant or transfused. If they have been, they're going to need a new sample on the day of surgery, unless it's been less than 3 days. In emergencies, there's a lot to say about emergencies, but you have to define a system in terms of how you're going to do the samples, how you're going to do the identification, in particular temporary IDs, and how you switch back to regular IDs. That's best left to individual hospitals. The specimen itself can be either a red top or a lavender top. Honestly, either one works. However, gel and solid phase actually prefer plasma, and that's because in a serum sample or a red top sample, the plasma may not clot completely, so you may not get a situation where that serum has gone all the way through, and you can have debris interference. On the other hand, though, when you use plasma samples, you have to remember that anticoagulation, because of the EDTA, actually inhibits some complement-dependent antibodies, and you can miss some of those, though that doesn't happen all that often. It's a possibility. Also, if the specimen is hemolyzed or lipemic, they're not good, and we try to avoid using them as much as possible. Okay, so we've got our patient sample. It's in the blood bank. We've already done our donor sample and our donor testing, so we're ready to go. What are we going to do? We're going to test our patient sample. We're going to do ABO testing, including both forward and reverse, or serum and cell grouping. We're going to do the RH test, which is generally done with an immediate spin monoclonal polyclonal anti-D. You really should, it's hugely important because this is difficult for old-time blood bankers to understand. You really, in modern times, should avoid doing a week D test, I should say, on a recipient. The reason for that is that most things that used to be called week D with our current testing are gonna be D positive, and the few that are actually partial D are deliberately going to be called D negative using the test, the anti-D that's available today. In particular, the D6 partial D variant, which is the most common, at least among Caucasians, is definitely called D negative by the most common anti-D used today. And that's exactly what you want. You want those people to be considered D negative so that they don't get exposed to any D antigens or any parts of the D antigen against which they can react. So basically, RHD testing in a patient is deliberately insensitive. We want partial Ds to be D negative. You don't want to go on and do a weak D test because you can end up calling one of those partial D people D positive, giving them D positive red cells and causing an issue with them forming an antibody. On the other hand, it's deliberately sensitive in donors because we want any donor that has either weak D or partial D to be called D positive because they theoretically at least, have some parts of the D antigen that can cause a theoretical response in a recipient. So I hope that's clear, and I hope you understand that. We also do antibody detection or an antibody screen on our patient sample. Important to know that an antibody screen, by definition, only has to be read at AHG. A lot of people will read it at immediate spin in 37, but it doesn't have to be. In fact, if you're doing gel and solid phase, or solid phase, that's all you're reading at is at the IAT or AHG phase. I mentioned before that FDA requires certain antigens to be present on screening cells, and you see them listed here. They're actually pretty close to alphabetical, so they're pretty easy to remember. And honestly, they're ones that you would expect, with the exception of a couple of usually insignificant ones thrown in there, like M and N and P1. And in fact, the ones on the second row there, Lewis A, Lewis B, M, N, and P1, are usually insignificant, but they're a required part. If the screen is positive, you have to identify the antibody. You have to determine whether it's a significant antibody or not, and that's going to be covered in the next podcast, so we won't talk about that anymore. If there is a significant antibody, then you need to, as best you can, provide antigen-negative blood. So who decides what's significant? Well, technically, each facility makes that decision and decides what is significant and what's not significant, but obviously there's a ton of published data to tell you what's significant and what's not significant. But each facility has to make a decision on what needs to be worked up and antigen negative red cell products provided, and in what cases that doesn't matter. Okay, so scooting right along, let's talk about the previous records check. It's the last thing we do before we do testing of both the donor and patient, to get testing and evaluation of both the donor and patient together. The previous records check is required by AABB standards. You have to look at the ABO and RH testing for your donor, specifically in the last 12 months, but most people will go beyond that. It's usually in the computer system. You also look for typing problems, significant antibodies in the past, hugely important to look at that, and history of transfusion reactions and special requirements. And you have to document any resolution that you do of discrepant results. For example, you see now the patient is B positive, and before the patient was B negative. You have to try and figure out what the deal was with that. The significant antibody check is really important because 1/3 of clinically significant alloantibodies will disappear after 1 year, and nearly a half of them will disappear after 10 years. So if you see a significant antibody in the patient's history, regardless of how long ago it's been, you honor that and you give them antigen-negative blood. You also look for, as I said, difficult testing and all those other things, but most important in this slide to look at the history of significant antibodies. All right, moving along. So now we've done our donor evaluation, we've done our patient evaluation. Now we're going to try and pull those two together and see and evaluate what goes together with these donors and patients. And we'll start by what components to select. Well, you select components in terms of what the provider has asked for, obviously, by the results of the serologic testing that you've done and by the results of the records check. And basically you use all that to provide the safest possible product based on the available information. One thing that's really important to remember is that special modifications are the things that often you'll see historically, but you may not see on the current order, because it's unfortunately difficult for all clinicians to remember all the things that are done. Irradiation in particular, and my personal philosophy on this, and this is just my philosophy, is that someone has an irradiation order. Irradiation, as I hope you know, is to prevent transfusion-associated graft versus host disease. If they have an order to irradiate a product, I will generally honor that, even if they don't ask for it, until such time as they tell me to stop honoring it. TAGVHD is a horrible thing to diagnose, and I would rather do the irradiation even if it's not specified on the order. Each individual facility can handle that whatever way they want to, but that's how I handle it. Okay, so once we have all this, well, how do we decide what to give? Well, let's start by looking at what ABO type to give. Here are the general rules. If you're doing whole blood, you got to go ABO identical. There's no way around it. There's too much plasma in there and obviously too many red cells in there to do anything other than ABO identical. If you're just doing red cells, on the other hand, what we're trying to do in this situation is protect those transfused red cells. So the transfused red cells need to be ABO compatible with the recipient plasma. In other words, a person who is blood group O and has anti-A and anti-B, a recipient that is, should only receive group O red cells to protect those transfused cells. The same thing is true with granulocytes, because granulocytes are always heavily contaminated with red cells, ABO compatible with the recipient plasma. FFP, on the other hand, you have to think the other way around. We're not transfusing red cells with FFP, so we actually want to protect the recipient's red cells. So you need to have those be ABO compatible with the recipient red cells as best you can. Platelets, on the other hand, you will read people say things like, it doesn't matter with platelets, and some people treat them that way. I will tell you that the preponderance of data that I see out there right now suggests that ABO identical is best with platelets, not only for reasons of a good response to the platelets, but also for potential reasons of hemolysis, especially in situations where group O platelets are going to non-group O recipients. That's a really dangerous thing, and it's not always dangerous, and we get away with it quite often. But if a platelet donor, happens to have a very high titer of usually anti-A, and you give that group O platelet to a group A recipient, you can actually see kind of a reverse hemolysis. The younger and the smaller the patient is, the more of a risk that is. I really try to avoid it when I possibly can. There's also data out there that suggests that ABO incompatible platelet transfusions can have patients that get those can have decreased survival, and nobody wants that. All right, finally, cryoprecipitate. There isn't any ABO type risk with cryo, though if you're giving someone large volumes, that's called into question a little bit. But in general, all ABO types are acceptable. For RHD compatibility, for D compatibility, basically with red cell products with a premenopausal female, you always want to give them DNEG unless you're in an emergency situation. That's just a general rule that everybody should go by. I don't think anybody would debate that. However, if you're in an emergency situation and you have to switch them, well, then you have to switch them. Certainly for D-negative males and D-negative postmenopausal females, they may receive D-positive in situations of urgency. I don't mean that you should just routinely throw out D-positive to these patients, but if you're in a situation where a trauma, for example, or a massive transfusion, it's okay to give them D-positive unless they've already formed an anti-D. We used to say that in that situation, 80% of patients would form an anti-D. Nah, not so much. Your handout talks about a reference of a really good study that shows only a 22% risk in hospitalized patients of D-negative patients of forming an anti-D in that situation. For platelets, there really is a very small risk, and we're seeing this more and more and understanding this more and more. Apheresis platelets generally have fewer red cells than whole blood-derived platelets, so the risk is smaller for apheresis. There's a recent study, again referenced in your handout, that showed a 3.8% incidence of anti-D formation over a 10-year time frame of D-negative patients who got D-positive platelets, a mix of apheresis and whole blood-derived, without getting prophylactic RHIG. My philosophy is that if you've got a childbearing age female who's D-negative and needs a D-positive platelet transfusion because of inventory issues or whatever, you should always consider RHIG, and generally I will recommend it. Okay, quickly, antigen-negative units are used for significant antibodies when we've identified a significant antibody, and there are a couple different ways that you can find antigen-negative units: the serologic method and the molecular method. Molecular is getting more and more popular, but basically serologic method looks with licensed anti-sera and finds units that are negative, or donors that are negative for particular antigens. It's much easier to do in a blood center because of the large numbers of donors, many of which have already been phenotyped. If you're in a transfusion service, there's the calculation in the handout on page 13 that takes you through how to tell whether or not it's going to be hard to find an antigen-negative unit for your particular patient. Molecular testing just looks for basically at genotypes, I should say, the donor for the main, and in fact a wide variety of genetic sites for blood group antigens. You still have to confirm those results because it's not licensed testing at this point. You still have to confirm those results with anti-sera, but it makes it easier to do your screens, basically. Okay, so the compatibility check we need to talk about, that's generally known as the crossmatch. And what is the crossmatch? Well, basically it's, a check for compatibility between donor and recipient, and it's especially designed to check for ABO compatibility between donor and recipient. When we say crossmatch, we really mean major crossmatch for the most part. It's when you test the recipient serum versus the donor red cells. Again, we're trying to protect those transfused red cells. A minor crossmatch, on the other hand, is the other way around. The donor serum versus the recipient red cells. The other benefit, aside from ABO, that you can get from doing a crossmatch is you can also detect antibodies versus low incidence antigens that may not have been represented on the antibody screen. You have to do a crossmatch if there's more than 2 mils of red cells in any product, which means you got to crossmatch whole blood, you got to crossmatch red cells and granulocytes. You generally don't have to crossmatch FFP or FP24, platelets, or cryoprecipitate. There are 3 types of major crossmatch, 2 of which are serologic and 1 of which is electronic. The first 2 are serologic, and let's talk about the first one, which is the anti-human globulin crossmatch. That's also known as a full crossmatch. Basically, it's done very commonly in the United States. It's required to be done for those who have significant alloantibodies. Most commonly, people are using either LIS potentiated tube crossmatches or gel crossmatches. PEG and albumin are somewhat less used, and solid phase is used even less. Basically, the anti-human globulin detects red cells that are coated with antibody. You have to read those reactions at the AHG phase, though depending on the platform you're using, you go through basically the same steps that you did in the antibody screen. It's just that you're testing your recipient's serum versus your donor red cells. Again, looking for incompatibility. Immediate spin crossmatch, on the other hand, is only used if no unexpected antibodies are present. So if the patient has no history of antibodies, they don't have any now, you don't actually have to carry your reactions all the way through to anti-human globulin. You can just do that beginning step, the immediate spin phase, and all that's doing is checking for ABO compatibility. It's possible that you could miss a low-frequency IgG antibody, an IgG antibody that doesn't react at immediate spin, that's against a low-frequency antigen, for example, but the risk of that is extremely low, and immediate spin crossmatch is generally a very safe thing to do. It's faster, obviously, than the full crossmatch, and decreases your use of reagent and potentially reduces your workload. The electronic or computer crossmatch, on the other hand, is only used, well, basically it's used in the same scenarios that immediate spin is. When the patient has a negative antibody screen, but also the additional caveat, it can be used when the patients have been ABO and RH typed on at least 2 occasions. In other words, you can do that several ways, and your handout talks about some options for this, but you have the current sample, obviously, your current testing, and you can either have previous testing that's present in your validated computer system, or you can repeat the testing on that current sample, or some places will go to actually, when it's the first time you're seeing a patient, forcing a second sample to be drawn from the patient to, again, verify. So once all that happens, then the computer basically compares the results of the ABO and RH from the donor and the ABO and RH from the potential recipient, compares them, makes sure that there is compatibility there, and you can issue the products that way. Here's just a flow chart that talks about how to do that. Since we're short on time, I'm going to skip that. Electronic crossmatch is obviously potentially faster, way less sample required and less reagent required for the most part, and has the potential to reduce workload, again, for obvious reasons. So what can happen when you suddenly have something pop up during a crossmatch? And I want to talk about this for just a second. If you have someone who has a negative antibody screen and all of a sudden they pop up with a positive crossmatch, there's some things that you should definitely think about. If the crossmatch is positive at immediate spin, you need to think about incompatible donor red cells. Basically, what that's telling you is that there's an issue there. This is what immediate spin crossmatch is designed to do. If you have an issue with how you typed the donor, with how the recipient was typed, if there's some incompatibility, it should come up positive on this test. So investigate that. Cold antibodies like anti-A1 can show up in immediate spin, or anti-M, for example, can also do the same thing. If it's positive at the AHG phase, or the Coombs phase, as it's also called, the most common reason for that is an antibody against a low-frequency antigen. You can also have issues with the testing that you've done, but that's the main thing that you should think about. Your handout goes into a little bit more detail on positive crossmatch after positive screen, but again, for interest of time, let's finish this off by talking about the label and final records check. Basically, once everything is ready to go and that unit is ready to go out the door, you tag or label that unit with generally a tag that looks somewhat like what you see in the picture there. That tag includes the recipient's two identifiers that we talked about before, has to have the donor unit number and the results of compatibility testing if such testing has been done. And it also has obviously the regular stuff that's on the label that you would normally see, and this is an ISBT label that you see right here from Johns Hopkins. Yeah, all that needs to be on there as well. But what we're talking about is the compatibility testing label and the pre-transfusion testing label that shows those results and must be on there as well. The clerical check, again, a big busy slide, but basically both at the time of the time the product is issued from the transfusion service and at the bedside, there's some things that have to be checked according to AABB standards, and you see them there. And it's just basically the things that we checked all along in terms of identification. So let's not take any more time to do that. Lastly, let's talk a little bit about the order types and the nomenclature. And here are the four main order types, for pre-transfusion testing. The hold clot is very uncommonly used. It's basically a clotted sample is held in the transfusion service, but it's not tested at all. It's just to have it there just in case something should happen. So again, not commonly used. Type and hold, same kind of deal. The only difference is that with type and hold, you actually do type ABO and RH, that particular recipient, but you don't do anything else. Again, some places use this. I haven't found it all that useful, but some people do it. The type and screen is a better test from my perspective. With a type and screen, you do a records check, looking for how the patient typed previously. You don't use that for your current typing, obviously. It's just for comparison once you do your ABO and RH typing, and you do antibody detection or an antibody screen. If that antibody screen is positive, then you need to go and identify the antibody, regardless of, in my opinion, regardless of whether, actually it's not just my opinion, regardless of whether they've ordered a type and cross or not. But if the antibody screen is positive, go ahead and identify the antibody and see if it is clinically significant. Type and cross match, on the other hand, includes everything that we talked about before, plus a major cross match, either serologic or electronic, depending on the patient's history. And then once you do that, then red cell units that are designated reversibly for that patient's use are set aside. If they're not used, they can always be re-released into the general inventory. That confuses some people sometimes. If the antibody screen is negative, okay, so let's talk for just a second. Oftentimes we have discussions with clinicians about for example, you're ordering every single case to be a cross-match. And so we're tying up a whole bunch of blood, yeah, reversibly, but it's temporarily unavailable for your patients, none of whom you're transfusing. If you find yourself in that situation, you can advocate for the use of the type and screen rather than type and cross, and clinicians always want to know, well, how fast can I get the blood? How does this work? Well, if the antibody screen is negative, then it's really easy to convert a type and screen to a type and cross. All you need to do is the ABO check, and that can be done with an immediate spin crossmatch, which takes very little time, or an electronic or computer crossmatch, which also takes very little time. You can also assure them that if the antibody screen is positive on your type and screen, then you automatically will convert that to a type and crossmatch after you identify the antibody. So you will determine what the antibody is, get antigen negative units ready. Obviously, that'll usually entail some communication between yourself and the clinician. And it's important to have that communication. Again, you can reassure them that we know how to handle this process. There's some variations in babies that are less than 4 months old. Basically, with pre-transfusion testing and cross matches, you can check the baby's ABO and RH and check the mom's antibodies because they're the same as baby. And after that, you don't have to do cross matches or serum grouping as long as you're staying within certain specific parameters. Finally, let's talk about the MSBOS, the Maximum Surgical Blood Ordering Schedule, which is basically a list of procedures that outlines what the appropriate blood order is for that particular surgical procedure. The order can be none, in other words, you don't need a sample at all, type and screen, or a type and cross match for X number of units. Most importantly, it needs to be hospital specific, and it needs to be approved and discussed widely with the clinical staff. It can be a really useful tool especially in situations where people are ordering types and crosses, for example, when they should be ordering types and screens. but unfortunately, it's not nearly as widely used as it used to be. It's a little bit of a hassle. In fact, it's in many cases, it's a lot of a hassle. This is an example of one part of the MSBOS from the University of Michigan that they published online. Thank you to them, specifically for cardiovascular surgery, where it talks about, for example, at the top left, aneurysm, thoracic resection, type and cross for 4 units. You see on the right, you see some procedures that would be type and screens. And in other parts of the MSBOS, you would see things that you wouldn't need a sample whatsoever. All right. Whew. So we have covered a whole heck of a lot of stuff. I really want to thank you for hanging out. Again, the Antibody ID podcasts are coming soon. I honestly, I just so appreciate you guys being here and hanging out and listening to this. Please send me feedback in whatever form you desire, whether that's Facebook or Twitter, or contacting me directly through the website. I am so glad that you were here. I'm so glad to have spent this time with you. I hope you enjoyed it. I hope it's been useful for you. Have a great day.